Welcome to the Sight and Sound Bites presentation from the Eye and Ear Foundation. And thank you for coming on board to a topic which I know is very popular. We have a lot of people signed up. It's an area that we're doing a significant amount of work on at the University of Pittsburgh. It's also an area that we're really trying to help in terms of being a leader in this area for what we want to do to help patients who have any type of optic nerve damage. So I'm going to get right into an introduction here, and then we're going to get started as soon as we can. But it's very important first also to do a little bit of housekeeping. So I'm Lawton Snyder. I'm the CEO of the Eye and Ear Foundation. So we support research to advance care for vision, hearing, balance, voices, and cancers of the head and neck at these two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds that we provide from the Eye and Ear Foundation to support research are only made possible because of philanthropic support. So we're sort of the lighter fluid to get these very big ideas and initiative projects started. And then, of course, the scientists support apply for NIH grants and other funding to keep it going as well. This topic is current updates in optic nerve research. Again, I think you're going to appreciate this topic considerably. Little housekeeping: chat is disabled on your Zoom today. We were going to ask that you ask questions through the Q&A function. Please refrain, if you can, from asking personal health questions. We can get back to you with those personal health questions, so you can send those to Craig Smith, whose email will be in your invitation. And please feel free to use the show subtitles function for closed captioning. And we want everybody to know we will be adding it to our email list for future webinars. Of course, you can ask to be removed at any time, but we do these webinars every other week to talk about the different topics that we're working on and supporting through the Eye and Ear Foundation. We have three presenters today, and they all have a lot of information to share with you. Dr. Larry Benowitz is a professor of ophthalmology. Dr. Benowitz is a former professor of neurosurgery and ophthalmology at Harvard Medical School and neurosurgical innovation and research professor at Boston Children's Hospital. He is now the professor of ophthalmology at the University of Pittsburgh. He and his colleagues are continuing research on regeneration of the injured optic nerve and preservation of retinal ganglion cells. We also will hear from Dr. Takaaki Kuwajima, Assistant Professor of Ophthalmology, faculty member of the Louis J. Fox Center for Vision Restoration. Dr. Kuwajima is an assistant professor of the Department of Ophthalmology at the University of Pittsburgh School of Medicine. He has 19 years of experience in research in neuronal development, injury, and disease, and his lab is currently focused on understanding the cellular and molecular mechanisms of how retinal ganglion cell protection, optic nerve regeneration, and restoration of visual function after optic nerve injury can be achieved. And then we have someone relatively new to the team, kind of coming back from previous time he spent in training with us, Dr. Peter Mortensen. Dr. Mortensen is the assistant professor of ophthalmology and completed his ophthalmology residency here at UPMC in 2020. Then he completed a neuro-ophthalmology fellowship at Houston Methodist Hospital under the direction of Dr. Andrew Lee in 2021. He worked at Houston Methodist Hospital until early this year, and when he returned to Pittsburgh as a full-time neuro-ophthalmologist until here just recently in May of 2025. So welcome all of you. And we are looking forward to a great program. I will tell you this again has been something we have been working on this. I've been with the Eye and Ear Foundation for 15 years. And almost from the very beginning of time that I've been involved in this organization, we have been focused on what we can do to try to enhance and really grow optic nerve regeneration research. We now have several members of the team who are working on this. Some of you you'll hear from today. You'll get a chance to ask your questions, but I will start off by telling you that we get a lot of questions already all the time about optic nerve regeneration because we are really trying to move this along as fast as we possibly can. I'll answer one question right off the bat before we even start because I know it'll be in there, and that we really are not doing any clinical research at this time in optic nerve regeneration. We're hoping Dr. Mortensen can help us get that started in the very near future. But there are such incredibly good reasons to be optimistic and hopeful for the future based on so much that's going on around the country and around the world. And you're going to hear from the group that's really on top of that, and they're going to share their stories with you. So we're going to start with Dr. Mortensen. Please, Dr. Mortensen, come on screen here and get us started.
Perfect. Yeah. Thanks so much for the introduction, Lonnie. And so we'll just start here. So I have no financial disclosures. And so just as an overview, today we're going to start talk about various optic neuropathies. And this is not an exhaustive list of all of them. There's hundreds of different causes, but some of the more common ones, as well as the treatments and some of the limitations that we have. And so an optic neuropathy in general is just a disease that damages the optic nerve and often will lead to vision loss. And so the optic nerve is the interface between the eyes and the brain. And although we think of it as a part of the eye, it's actually technically more a part of the brain and the central nervous system itself. And it lacks the ability to regenerate. So as opposed to peripheral nerves throughout the rest of the body, if the optic nerve has a transection or significant damage to it, it doesn't have that ability to regenerate itself. And so a sick nerve that is affected with the disease process has an opportunity to heal and have some return to function, but a dead nerve does not regenerate. And so there are numerous causes, including toxins, nutritional deficiencies, brain tumors, inflammatory diseases, infections, genetic disease, intracranial pressure elevations, glaucoma, and multiple others. And so diseases of the optic nerve currently are focused more on maintaining what we have, maintaining the level of vision, maybe bringing some vision back if the nerve is sick but not dead. But unfortunately, in many cases, we're limited by the fact that we don't have any regeneration abilities at this point in time. And so glaucoma is perhaps the most common optic neuropathy, and it's defined as an optic neuropathy with characteristic visual field defects. But in reality, we often think of glaucoma as a disease associated with high pressure in the eye or high intraocular pressure. And so the most common form of glaucoma is primary opening of glaucoma, and this results in progressive vision loss over a period of several years. And one of the difficulties with diagnosing glaucoma is that patients are generally completely unaware of their visual field loss until it's too late in the disease process. And by that time, there's not much we can really do other than try to maintain the vision that remains, but we can't regenerate what's lost. And what we often observe over time is that the optic nerve will progressively thin and lose fibers. And so the treatments are focusing on maintaining rather than restoring the visual field findings and the vision loss that occurs from glaucoma. And so for glaucoma, a typical disease progression is that under normal circumstances, we can see that very top image where we just have the normal blind spot of the eye and an otherwise normal visual field. And so this is basically a perfect field, but over time, we can see we get these arcuate field defects, the top and bottom. And eventually, what we get, if it's untreated or if there's difficulties treating it, is that you end up with a central island of vision that we can see here in the bottom with the complete loss of peripheral vision. And so someone could have 20/20 vision, but they could have essentially as if they're looking through a straw. And if nothing's done, eventually this would progress to complete vision loss. Another type of optic neuropathy we commonly see is a traumatic optic neuropathy. And this can occur due to direct trauma to the eye, or it can actually occur due to damage to the periorbital region. Someone's hit around the eye, and then the shock waves from that injury are actually transmitted to the optic nerve behind the eye. And so there's a lot of controversy regarding the treatment for traumatic optic neuropathy. And so the first thing to note is that often we see some improvement that's observed without treatment. But in many cases, we see a course where there's not really any significant improvement or worsening beyond the initial first few days. Steroids may have some benefit, but there's no study that proves their usage. And on top of that, there was a study that was previously done known as the CRASH study several years ago called corticosteroid randomization after significant head injury. This study didn't really deal with optic neuropathy per se from the trauma, but what they found is that giving steroids to patients who had a severe traumatic brain injury actually have an increased risk of death related to those steroids. And so many of our patients with traumatic optic neuropathy, it's not just the optic nerve that was damaged, but they're coming in with multiple other findings and a really severe head injury itself. And so giving steroids actually could put this patient at higher risk of a life-threatening issue. And so that's another problem with treating this disease. Sometimes we've tried treatments with vitamins or supplements such as B12, but this is unclear whether they actually help. And optic nerve decompression has been considered, but this is a very risky procedure, and we're probably more likely to actually cause damage to the nerve by doing so. But if there's a hemorrhage behind the eye, that might be the one exception where we can decompress the eye itself and lower the pressure, but there's not much we can do about that nerve damage itself once it's set in. There's also multiple inherited optic neuropathies. The most common we see is autosomal dominant optic atrophy. And so, as the name implies, it's inherited in an autosomal dominant manner. And so, what this means is that you only need one bad copy of the gene to actually manifest with the disease. And if you have a bad copy of the gene, there's about a 50-50 chance that each of your children would get that mutation of the gene. And so the most common mutation with autosomal dominant optic atrophy is known as the OPA1 mutation. And so generally this disease presents with painless progressive vision loss over time, affecting both eyes. The visual acuity is usually better than 2200, but there's a very wide range of visual acuities. And so what we see here is a lot of variable expressivity where there's a wide range of visual impairments. We've had some patients who for their whole life with the best pair of glasses, we can never get them past 2030 or 2040. And then they have a child who has significant visual impairment. And we test both and find out that, both have this gene, but one of them manifests with a much more severe presentation. Like a lot of visual diseases, what we find is that this is associated with mitochondrial dysfunction. And there's no established treatment, but sometimes patients have been treated with B12, coenzyme Q10, idebenone, and multiple other therapies, but there hasn't been any proven benefit of any of these. And then another gene disorder we could see is called Leber hereditary optic neuropathy. And so for this, it's the second most common inherited optic neuropathy. It's inherited also via mitochondrial gene mutations. And it generally presents with vision loss in one eye, followed by vision loss in the other eye in the weeks to months afterwards. Often it's in young male patients, often college age up to maybe early 40s. It's very classic to hear of someone who went out for a night of heavy drinking, and then the next day they lost vision in one eye and then the other eye shortly thereafter, or someone who took a lot of caffeine like Red Bull and other drinks that contain a lot of caffeine can also cause this to sometimes manifest. And so what we find though about this gene is that it has what we call incomplete penetrance, meaning that if you have this gene, there's a 50% chance it will present if you're a male. But for women, it's about 10% or less. And so it's not uncommon for a patient to present with this pattern of vision loss and not have any known family history because it's passed down from the mother to all the children. And so in most cases, the mother will have the gene, but not actually manifest with the disease. And so there's actually three most common mutations with this disease. And so 11778 is the most common and 3460 is the third most common. And these two, unfortunately, have a very minimal chance of recovery. The second most common gene would be the 14484 mutation. And unlike the other two, this one actually presents with spontaneous recovery. And in one case I saw over the past year, a patient actually dropped to around the 2200 level in both eyes within a matter of weeks, and then actually recovered to 2020 in one eye and 2030 in the other. And so sometimes that one actually does have a good prognosis. And then the treatments are also debated, but coenzyme Q10 is sometimes given. There's also idebenone, and this actually in various trials does seem to stabilize the vision loss that occurs. We often recommend avoiding some mitochondrial stimulants, so alcohol, caffeine, and certain medications that can stimulate the mitochondria, and this can help prevent further worsening. It can also prevent further vision loss. If a patient loses vision in one eye, our goal would be to try to prevent the vision loss in the other eye, and we've had moderate success by avoiding these mitochondrial stimulants. And there are also some recent gene therapy trials to actually deliver the gene for the what we call ND4 enzyme and try to restore visual function in the ganglion cells that are affected. And so there's some initial studies on this that actually do show promise for this particular disease. There's one of the most common optic neuropathies we see is called NAION. And so NAION has a long full name known as non-arteritic anterior ischemic optic neuropathy. And so basically it's due to lack of blood flow to the very front or anterior portion of the optic nerve head. And when we look in the back of the eye on day one, we expect to see that the optic nerve is swollen. And so this is actually the most common cause of acute unilateral painless vision loss in a patient who's above the age of 50. It's often due to vascular risk factors like hypertension, high cholesterol, diabetes, obstructive sleep apnea are all very strongly associated, as well as certain medications such as phosphodiesterase inhibitors such as Viagra and Cialis. And for this disease process, what we find is that most patients who have it have a crowded optic nerve, which is what we call a non-modifiable risk factor, meaning patients are born with this and it's something that can't be changed throughout life. And so because of this, a lot of patients will actually develop this in both eyes. And so if an individual has this in one eye, there's a 15% chance this can happen in the other eye at some point in time. And of note, we sometimes do call this a stroke of the optic nerve, but I do have to point out that this is actually a misnomer because it's not technically a stroke. It's actually small vessel disease, and having NAION does not require referral to stroke neurology. And then over time, what we can see is that the optic atrophy eventually progresses to, sorry, the optic disc edema eventually progresses to optic atrophy over a period of about 3 to 6 months. And in many cases, patients will present with this field loss that affects the bottom or top half of the vision to where the top or bottom half is completely gone. And in some cases, it can progress from there, but in many cases, it stays about the same. And unfortunately, there's minimal recovery. Even if we administer steroids and other treatments, we often find that there's really not much that can be done for NAION other than prevention of further vision loss by modifying the vascular risk factors. Another disease we commonly see in neuro-ophthalmology is called giant cell arteritis. It also goes by the name temporal arteritis, and you'll see the abbreviation GCA or TA for this disease. And this can cause vision loss due to multiple mechanisms, but it often causes arteritic anterior ischemic optic neuropathy. So the last disease we talked about was non-arteritic, and this one is arteritic. And arteritic simply means that this is due to inflammation of the arteries themselves. And so this generally affects individuals above the age of 50, and most patients we see are probably in their 70s for this disease. And often there can be other associated symptoms that all occur around the same time, such as headaches, scalp tenderness, polymyalgia rheumatica, which is basically pain and lack of function in like the hips and the proximal muscles, like the shoulders also. You can get what we call jaw and tongue claudication, where you get pain with exertion of either the jaw with chewing or tongue. There can also be transient episodes of vision loss before the vision loss sets in. So some patients will report having multiple episodes of vision loss lasting minutes in the affected eye before the vision loss actually develops. You can also get double vision or diplopia that can either come and go or be permanent. Many patients with giant cell arteritis also have unintentional weight loss. We'll mention that they lost a pound per day sometimes for the past few weeks before seeing you. And then many cases of fever of unknown origin in patients above the age of 50 actually are attributable to giant cell arteritis. And for giant cell arteritis, the problem is there's no specific laboratory test that can prove that someone has GCA, but the markers of inflammation are elevated in about 80% of patients. And those markers are the sedimentation rate, C-reactive protein, and platelets. But it should be noted that just because the markers are normal doesn't mean it's not GCA. And 20% of patients with GCA actually have normal markers. The gold standard test is actually a temporal artery biopsy, where we biopsy the artery in the temple up here. But we've also found some usage of the temporal artery ultrasound, which is less invasive. For GCA, we often treat with high-dose steroids and steroid-sparing therapies. And so one of the issues that we have with GCA is once vision loss occurs, we rarely see any significant improvement afterwards, even if we start steroids immediately after the vision loss. And I've even had patients who came to the hospital immediately after the vision loss, started steroids, and they even had further vision loss despite getting the correct treatment. And so it's very difficult to slow down that inflammation once it starts. And the problem is we've had some people progress to the point that they've completely lost vision in both eyes to the point that they can no longer see light. And unfortunately, once we hit that level, it becomes permanent. And so the challenges with this disease are that the laboratory markers are often non-specific, meaning that multiple diseases can cause elevation, and unreliable in the sense that 20% of patients with GCA will have normal inflammatory markers the entire time. We can see at the variable, the presentation can be highly variable because there's numerous symptoms and manifestations. And the worst cases are those where vision loss comes first before any other symptom, because there's essentially no warning. Even with diagnosis, the diagnosis can be unclear, even with the labs, the biopsy, and with additional testing. We have many patients who have presumed or likely GCA, but we don't have a definitive diagnosis. And because the disease is treated with steroids and other high-risk medications, we have to be mindful of the fact that if we're not completely certain of the disease process, that we may be causing more risks for the patient by treating with these medications that have numerous other side effects, including death. And so the current GCA treatment goal is to prevent any further vision loss rather than recover vision. And so this is one of the biggest challenges with this disease. And even with the correct treatment, it's possible to still have further vision loss. And then move on to optic neuritis. And so the most common presentation would be unilateral or bilateral vision loss affecting basically one or both eyes over several hours in many cases. There's often pain with eye movements associated with it. And when we get an MRI of the brain in orbits, we expect to see that the optic nerve basically lights up, meaning enhancement of the optic nerve. And so the most common cause we see is generally multiple sclerosis, but there's other diseases that are less common, such as neuromyelitis optica or NMO, and myelin oligodendrocyte glycoprotein associated disease, or MOGAD, that can also cause optic neuritis. There's multiple other infectious and inflammatory diseases that can cause it. Those are some of the more common presentations. And what we find is that the presentation and prognosis are highly variable. So for MS, most cases of optic neuritis actually have a good prognosis. We typically see a moderate response to steroids where the improvement occurs over several weeks, but typically 90% of patients or more have a visual recovery of 20/40 or better. And on top of that, MS optic neuritis usually almost always affects one eye at a time. It's very, very rare to see both eyes affected at the same time with MS, but if someone has the disease, it's possible to have one eye affected during one flare and then the other eye later on, months to years later. NMO is probably the most severe of these diseases and results in vision loss in one or both eyes. And often there's a poor response to steroids. And so like GCA, our goal is often to try to retain what we have rather than bring vision back. But I have seen some really excellent recoveries in patients with NMO who presented very early on to the hospital. And then MOG can present with one or both eyes and is often extremely steroid responsive. And so many patients will have visual recovery in a matter of just 2 or 3 days even. And so in all these cases, though, even if we give steroids immediately, we typically find that the optic nerve loses fibers and becomes very pale over time. And so that's one of the limitations, is that even with the optimal treatments, there's only so much that can be done. And NMO in particular has a very, very high risk of blindness if untreated. And so we just have to try to retain the vision that we have, but we can't really bring back what's lost. And so one thing to note is for MS, there's the optic neuritis treatment trial that applies. This study was done several years ago, and it was investigating the efficacy of different corticosteroid regimens for treatment of optic neuritis. And we actually divide the patients into 3 treatment groups, and there was the high dose steroids or IV methylprednisolone. There was a lower dose of oral prednisone, and then last would be the placebo group. And what we found for MS optic neuritis is that even though we recommend giving steroids, there was actually no difference in visual recovery between giving the high dose steroids and placebo at 6 months out. Early on, the steroids do help patients get better faster. But they don't ever change the end prognosis from what we've observed. We also find that high dose steroids can temporarily reduce the risk of MS, but the effect only lasts for about 2 years. And then for oral steroids, we find that giving like a low dose of oral steroids is actually associated with a high risk of relapse and progression to MS. And so it's often mentioned that it's better to essentially do nothing, not give any steroids, than it is to give sort of a low dose of oral steroids in these cases. And so just to wrap things up, so for optic neuropathy, there are multiple causes, and we can see, inflammation, infection, demyelinating diseases like multiple sclerosis, compression, genetic and hereditary conditions, trauma, glaucoma, as well as toxins and nutrition can come into play too. And for the optic nerves, they're part of the central nervous system, and they have very limited potential for recovery. And so we can see that sick nerves can show improvement in function, but dead nerves cannot regenerate. And so much of our treatment is focused on preserving the remaining optic nerve function and preventing further episodes of vision loss, but we can't bring back what has already been lost. And so I'm going to segue into some of our other speakers in terms of the fact that our research is eventually going to aim to restore and regenerate the optic nerves.
So, Dr. Mortensen, that was a terrific presentation, and I learned a lot. It was a kind of a summary review course in ophthalmology, which I never had. So, I get patient requests about these conditions all the time. Practically every day, I get a request about someone who has lost sight, either through a genetic disorder or inflammatory condition or traumatic injury. And I have a standard response, which is we sure wish we could help, but the ability is still limited and there's a lot more to be learned. So the talk that I'll be giving right now is at a, kind of a different different way of analyzing these issues. And that is taking an animal model, in most cases mice or rats, and because the basic biology of the optic nerve is similar across all the mammals, um, we can learn things using small animal models where we can look at several cases a week. In case of Dr. Kuwajima, it's more than that because he's doing a phenomenal job in testing therapies and developing therapies. But the animal models give us the opportunity to test different hypotheses, to make discoveries, to look at the role of different genes. And the field has really progressed in the last 25 years. So yeah, so my talk will be basic research in optic nerve regeneration. I gave it a Roman numeral 1 because Dr. Kuwajima will be giving part 2 of this, further discoveries along these lines. So in the animal model, we do these studies in small animals. And again, the biology, as far as we know from extensive studies of genes and anatomy, neurotransmitters, types of cells involved, is remarkably similar. So the experimental paradigm here is we injure the optic nerve a little distance behind the eye, and the axons, the nerve fibers that originate in the projection neurons of the eye. I'm sorry, I should have given an overview of the structure of the retina. The retina is really the business part of the eye where the nerve cells are located that gather information. It's a remarkable computer where a huge amount of information is processed right in the level of the retina itself. And then that information converges on what are known as the retinal ganglion cells. The retinal ganglion cells are the integrators of information in the eye, and then they in turn send information back to the brain. So the optic nerve damages damage to the optic nerve damages the nerve fibers that originate in the retinal ganglion cells. And those cells cannot regenerate their axons, as Dr. Mortensen pointed out. They begin to die after their axons are injured with no hope of recovery. Here in the lower left is Dr. Chen Yin, who is the heroine of much of this story. So we made really an accidental discovery many years ago, and that is in this case where the optic nerve is injured, we made the bizarre discovery that if we cause a limited inflammatory reaction to take place in the eye, we did this accidentally at first by nicking the lens. That causes inflammation. We subsequently stopped doing that. We used other agents to promote an inflammatory reaction. And what we discovered was something really, really surprising. And that is that that intraocular inflammation causes the retinal ganglion cells to transform back into an early developmental state. So whereas in the normal state of the retinal ganglion cells, where they're expressing genes that maintain the stability of the optic nerve, this kind of provocation, this kind of stimulus, causes the retinal ganglion cells to revert to an early developmental stage. They turn on a whole host of genes. These won't mean much to most people. And with that, the retinal ganglion cells, many of them don't die, and they start regenerating axons down the optic nerve. So this was a really remarkable discovery. Here's an image actually of axons regenerating distal to the injury site. This is a long section of the mouse optic nerve. The injury site is here. And what you're seeing is with this inflammatory agent called zymosan, we get many of the retinal ganglion cells regenerating axons down the optic nerve. A few years after we made this discovery, my close neighbor at Boston Children's Hospital, Harvard Medical School, Jigang He, made a complementary discovery. He discovered another way to get retinal ganglion cells to regenerate axons by removing what essentially amounts to a break in nerve cells. There's a gene, a protein called P10. P10 suppresses the growth ability of nerve cells. And Jigang's lab discovered that if you delete that gene using gene therapy, you can also get regeneration. That's this bottom image over here. And then we simply asked the question, what happens if you put these two things together? So that is cause inflammation and knock out the gene for that suppressor. And do those two have complementary effects? And the answer was it sure does. And so putting together our stimulus, the factors that arise from inflammatory cells, plus knocking out that suppressor of regeneration, gives us approximately 10 times as much regeneration as either treatment alone. So this was far and away the most regeneration anyone had ever seen up to this point. And if we extend it, and this was now done by Dr. DeLima, who's now a member of our department here in Pittsburgh, we get axons growing all the way down the length of the optic nerve. This blow up here shows axons at the very far end of the optic nerve, about to enter the brain. And in Dr. Talima's studies, she found that some of these nerve fibers actually find the proper places in the brain to form connections again, with a very modest level of visual recovery. So this was very hopeful, and this was one of the things that stimulated the National Eye Institute, part of the National Institutes of Health, to begin what they called their Audacious Goals Initiative to restore vision to the blind. And we were recipients of a grant from them, and this has helped continue it. But the real big effort is happening now in Pittsburgh with another federal impetus. So let me go through this very quickly. What are the molecules that cause this regeneration to occur? We realize that these must be molecules that are made by inflammatory cells. And prior work in the field had studied some of the well-known growth factors. You may have heard of BDNF. That's been gotten a lot of attention in other contexts. BDNF, CNTF, there's a whole list of well-known growth factors, but it turns out it was none of those. None of the usual suspects were the mediators of this phenomenon. So we did a whole lot of basic biology and chemistry, and we discovered the molecules that are causing this regenerative growth. One of these is a protein called oncomodulin. So these are cells of the immune system that come into the eye when we cause inflammation, and they're making loads and loads of this protein, oncomodulin. So this led to a kind of a major publication from our lab where we showed that if we package oncomodulin into slow-release polymer beads, we can get the optic nerve to regenerate considerable distances. And then we discovered that there's another molecule, another protein being made by inflammatory cells, a protein called SDF1. And when we put together SDF1 plus oncomodulin, this is just showing this panel showing that the inflammatory cells make the SDF1, that's the red staining over here. Let me skip that and show here that if we put together these defined molecules, now we don't have to cause inflammation anymore. We know the proteins, we put the proteins together. We use virally mediated gene therapy to keep producing those proteins in the eye, and we can get more regeneration than we got from causing inflammation. The bottom panel shows that these are really the molecules that do the trick, because if we use antagonists, if we prevent these proteins from binding to their receptors on retinal ganglion cells, we pretty much eliminate the regeneration caused by inflammation. So to summarize that then, oh, here comes that yellow circle, didn't go away. But anyway, just to summarize that part, we know that inflammatory agents like zymosan activate immune cells, macrophages, neutrophils, and these cells, surprisingly, turn out to make what are called growth factors, proteins that stimulate nerve cells to regenerate their axons. So now we can get around inflammation. Of course, we don't want to cause inflammation intentionally, and just use these defined molecules to cause significant levels of axon regeneration. Having found these strange molecules that were really on nobody's radar screen, it occurred to us that maybe there are more of these remaining to be discovered, more previously unknown stimulants of nerve regeneration. So using modern methods of seeing what all the genes are that cells express, an experiment was done by, again, Dr. Yu-Chin Yin. This is again back in Boston Children's Hospital, Harvard. What Yu-Chin did was to dissect the retina from a mouse, dissociate the cells, and then separate the retinal ganglion cells. What we did was genetically label the retinal ganglion cells with a fluorescent red protein, so that it makes it easy for us to separate the retinal ganglion cells from all the other cell types that are in the retina. Actually, the retinal ganglion cells, the ones I mentioned as the business parts of the retina that send information back to the brain, only represent less than 1% of all the cells that are in the retina. So the other cells in the retina are things like photoreceptors, interneurons that mediate signal transmission from the photoreceptors to the retinal ganglion cells. So using modern tricks, we separated the retinal ganglion cells, examined all the genes that they're expressing, and then what we did was to see what do those genes code, what proteins do they code, and what we discovered is that those genes code about 70 different receptors to growth factors that we never knew about. And so this is telling us that in addition to receptors to the molecules that we found causing regeneration, there were still 60 plus more that had never been studied before that might induce regeneration. So what Yu-Chin did then, is that annoying yellow circle again. I'm not going to try to get rid of it. But what Yu-Chin did was to screen many of these the factors, the proteins that bind to the receptors that retinal ganglion cells make, and she really struck gold. She discovered several previously unknown growth factors that cause retinal ganglion cells to regenerate their axons. So here, this one called IL-12, the second panel down, here is the injury site again, and just putting IL-12 into the eye causes retinal ganglion cells to regenerate axons. And something to be emphasized here again is that normally there's zero regeneration. There's just none at all. But with these molecules, we're able to get, more and more and more. And that brings us to Dr. Kuwajima's work that you'll hear about in a moment. So Dr. Kunche Chung at Pittsburgh has been working with us and with Yu-Chin back in Boston. But Dr. Chung has been able to use organoids developed from human stem cells. And then with those, he's able to find out how do human retinal ganglion cells respond to the growth factors that we're finding. And so in this bottom panel here, what you're seeing in the bright object in the center in the bottom right panel is an organoid that represents most of the cells or all the cells that are present in the human retina. And what Dr. Chung finds out is that when he treats these organoids with this factor that Yu-Chin Yin discovered, he can get human retinal ganglion cells to extend axons. So this is the beginning of studies that are telling us that these molecules that we're discovering in lower animals are directly relevant to improving axon regeneration for human retinal ganglion cells. Then I mentioned earlier that one of the strange things, or maybe I forgot to mention it, one of the strange things that causes regeneration is injury to the lens. Now, of course, you'd never want to do this clinically, but what we discovered and what another postdoctoral fellow in my lab, Dr. Fanny Fang, or Chan Fang, made a very strange discovery, and that is if you injure the lens 2 weeks, not 1 week, but 2 weeks prior to optic nerve damage, that injury to the lens causes remarkable regeneration. That's shown in this lower panel here, LI, pre-optic nerve condition, optic nerve damage, we call it conditioning lens injury. And bizarrely enough, if you do that twice, all Dr. Fang is doing here, is injuring the lens 2 times, and she's getting astonishing levels of regeneration. So we're now trying to figure out why that happens. It turns out it's not any of the factors that we discovered. Something else is causing that to happen. And I guess the point I'm trying to make here is that we have multiple leads for stimulating regeneration. And we'd like to identify the mediators of these. And again, in Dr. Kuwajima's work, we'll see what happens if we put some of these things together, whether there is complementarity and whether we can get astonishing levels of regeneration. Here, for example, we're putting together this lens injury with another treatment, and we're getting, I think this is like 4 or 5 weeks, we're getting axons growing the entire length of the optic nerve. And then they enter the brain and they go into the parts of the brain where the eye projects. And then the final piece of data I'm going to talk about is Dr. Shah. But Dr. Shah is now back in China. She's now an associate professor in China, and she made an astonishing discovery. So the way growth factors work is that they bind to what are called receptors on the cell that responds to them. And by binding to these receptors, a cascade of events, a cascade of molecular events is initiated. And I'll try to make this long story short. What Dr. Shah discovered is that one particular receptor is enough. Just expressing the receptor, you don't even need the protein that binds to it. If you just simply express the receptor, that causes regeneration. And you don't need the growth factor, you just need the receptor itself. And so I'll just quickly describe what these things are. These panels are the IGF-1, SDF1, oncomodulin. These are known growth factors that we discovered and other people discovered that stimulate regeneration. And what Lili Shah's group discovered is that if you increase this receptor and treat with any growth factor whatsoever, you'll double or triple the amount of regeneration that you get. And then on the other hand, if you knock out the gene that encodes this receptor, nothing else, none of our stimuli can stimulate regeneration. So this discovery is really remarkable. It tells us that this kind of receptor that's been hiding in the background is the key to regeneration. You can't get any regeneration without it. And just by adding this receptor, you then add it to other things, to other treatments, and you get remarkable levels of regeneration. So then, just mentioning then, summarize some of the stimuli that cause regeneration. I mentioned some of these, not all of them: conditioning lens injury, oncomodulin. These are just a whole lot of words. You're going to hear more about these in the future, I hope. And then this last item, this receptor, that alone is like the linchpin for regeneration. And then this is others that have been discovered in our lab and other labs around the world. And again, this brings us to Dr. Kuwajima's work. The challenges here are, can we also get the retinal ganglion cells to survive in ways that enable regeneration to occur? So it turns out that some of the best ways to cause retinal ganglion cells, injured retinal ganglion cells, to survive, we and other groups have discovered ways to completely protect retinal ganglion cells that have had their axons injured. But when you completely protect the retinal ganglion cells, you block their ability to regenerate axons. We are getting, pretty impressive regeneration, but it's not enough to really restore the kind of vision that will enable our mice to read again. I'm joking, but that really will be clinically relevant. And what is our last point here? To get the axons to find the appropriate places in the brain and to form a map of visual space in the brain. So this is my last slide here, but there's a few parts to it. So we were fortunate to receive one of these ARPA grants from the federal government, Advanced Research Program for Health. This was initiated by President Biden. It includes things like curing cancer, but restoring vision to the blind is another part of that program, the ARPA program. And our team here at the University of Pittsburgh garnered a significant fraction of the money dedicated to vision restoration. So the team is Taka Kunche Chang, who I mentioned, Samara, who I mentioned, Boris Rosen, John Ash, the director of research here at Pittsburgh, and myself. And the idea here is first use the mouse model for for sort of quick throughput to test the number of treatments. So we know already in the mouse that we can injure the optic nerve, give various kinds of treatments, gene therapy, and get significant regeneration. The next step is moving up to a larger animal model, to a rat model, but then we're going from there to small pigs, and then hopefully on to primates, the non-human primates. But we're kind of working our way towards that now. So the idea here is to completely transect the optic nerve. And we know from studies that were done by a great neuro-ophthalmologist years ago, Alberto Aguayo, that you can attach a piece of like sciatic nerve, peripheral nerve, to the cut end of the optic nerve and get a lot of axons regenerating through that peripheral nerve. So what we'll be doing here at Pitt is combining our treatments that promote regeneration, and again, things that are being discovered through the combinatorial treatments from Dr. Kuwajima, combined with putting different kinds of nerve grafts or peripheral nerve or growth factors or other polymeric substrates at the cut end of the optic nerve in order to get really remarkable levels of regeneration in animal models that closer and more closely approximate the human visual system. So this was my team at Boston Children's Hospital. At one point, it's almost up to date. These are other lab members, collaborators, funding sources, the NIH for many years. And I think that's it. So thank you for your attention.
Hi, thank you, Lali, for showing amazing work and studies. And hi, I'm Takaaki Kuwajima. My lab is focused on understanding the cellular and molecular mechanisms of RGC protection, optic nerve regeneration after optic nerve injury. So today I will present how we conduct optic nerve regeneration studies at Pitt Ophthalmology here, using some examples such as our MBB statin therapies and also our ongoing collaborative project. So I have to disclose two things. First, Dr. Badilak and I have filed a patent application related to this work. And also Dr. Badilak holds an equity interest in the ECM therapeutics and serves as chief scientific officer for this company. So before jumping to our recent findings, I will show you some research background. So for example, in the adult central nervous system, a lot of axon regeneration inhibitory molecules exist in the environment. So when I was a postdoc at Columbia University, so we set up the drug screening using a neuron and also inhibitory molecules such as MAG co-culture system to mimic this inhibitory environment. And we tested 50,000 chemical compounds to identify drugs which could overcome this inhibition and also promote this axon outgrowth, and hopefully we can use for optic nerve regeneration. And then we finally identified the FDA-approved drugs, statins, as best candidates. So each statin has a different efficacy, and then we found that that cerebrostatin, the best, and also fluvastatin was the second strongest statin on the axon outgrowth using this culture system. So as Lali mentioned that mouse optic crush model is one of the well-established nerve injury animal models. So using this, and we found that after cerebrostatin injection into the eye after optic nerve crush, axon regeneration was observed, like here. However, we found that several issues. So axon regeneration is still limited, and RGC protection is weak. And also cerebrostatin is not available in the market because of strong side effects. So we have to solve these kind of issues. So now we have great privilege in Pittsburgh here, and we set up an exciting collaboration with Dr. Steve Badilak, a professor at Pitt. So his laboratory is focused on the matrix bound nanovesicles, MBV. MBV is a critical component of FDA-approved ECM extracellular matrix biomaterials, and also exists in the healthy tissues. And the most exciting findings are MBVs are neuroprotective reagent in the animal model of glaucoma. So we decided to investigate whether this new combination therapy using MBV and also fluvastatin, which is still available in the market, enhances RGC protection and optic nerve regeneration after optic nerve crush in the mouse. So Greg Campbell in my lab, he just found that in a combination of MBV and fluvastatin more strongly promoted RGC protection and also optic nerve regeneration compared to the either statin or MBV alone. We also found that some interesting cellular mechanisms here. So we checked the immune responses by the combination therapies. So we found that they increased the number of immune cells, such as neutrophils and monocytes, by the combination therapies, but not either statin or MBV alone. So we also found that those immune cells mediate RGC protection and axon regeneration. So I hope you remember that Lali showed that those immune cells actually mediate RGC protection, axon regeneration. So that's we just connected finally. So Then we set up the additional collaboration with Dr. Vijay Gonantran and his surgical team at Wake Forest School of Medicine. And we investigated MVV and fluvastatin therapy in pigs after optic nerve crash. As we observed in mouse, we actually found that MVV fluvastatin combination therapies showed a high RGC protection and also optic nerve regeneration. And also we noticed that this treatment reduced optic nerve degeneration, and minimized defects in the visual functions after injury. So now we are very excited to move forward to the next level using the non-human primates. So hopefully we're going to get the same results in the monkeys after injury, and hopefully we're going to use those therapies for humans in the near future. So this is the last slide, and I'm going to share our ongoing collaborative project funded by ARPA-H. And as Lolly mentioned, that one of the goals of this project is to establish effective regenerative therapies after optic nerve transection, which is more challenging compared to the optic nerve crash. So we have established large collaborations with outstanding scientists and experts at Pitt and also other universities. So we decided to use a validated single treatment by modulation of the epigenetic factors, intrinsic signals, and cytoskeletal axonal structure using AB viruses, but also non-viral reagents. Based on those validated single treatment, now we have been testing 45 new combination therapies. So hopefully we will identify novel and robust therapies for optic nerve regeneration and RGC protection after optic nerve transection, and hopefully whole eye transplantation in the future. So this is the last slide, and I really thank my lab members, especially Clark Campbell, for this MVV statin therapies, and also we thank our other collaborators. And then finally, we are grateful to have general support from Mr. and Mrs. Fox and the other donors, foundations, DoD, and ARPA-H. Thank you very much for listening.
Thank you all, and thank you, Taka, for bringing up the Foxes and the Fox Center for Vision Restoration. We've certainly been, as I said, focused on this my entire time here at the foundation, and Louis Fox has been right there with us, supporting it as well as participating in every way that he can. So this is more exciting than I thought it would be, and I thought it was going to be exciting, to be honest, because I just, again, we've been seeing this over and over, the slow progression, which you'd have to say, is normal, but with science, it's sort of it builds on itself. But wow, great progress, and how exciting to see all these groups working together. And then, of course, we've added so many here, people working here at the University of Pittsburgh, and so thank you to all. And I will, remind our audience too, we're really lucky, with Larry Benowitz. Larry's a pioneer in this work, and it's great to get this overview from him. We have a lot of questions. I'll go ahead and get to those. The first question I'll just quickly answer myself. Honestly, was about our NIH funding for the and whether or not that's the reductions in NIH funding, if any of them are affecting this work that you're talking about today. Fortunately, no. There's not any cuts to the ARPA-H program, which you heard about, that we now have a big grant to get things done. Certainly, the University of Pittsburgh, as all universities across the country, are receiving the impact of the changes at the NIH, and we definitely have lost grants, but not any here in optic nerve regeneration. I think that'll probably be as much as that you need to hear for now. We're obviously concerned, and if just like we're educating you here, we're going to probably also ask you to be good, educated citizens of the United States and do what we can do to make sure that we support research, because it's very important. So when we use the words near future, one question here, can we be more precise? That's a tough one. Does somebody want to take that in terms of response to that? It's one we do get asked frequently.
Well, I get many emails from people around the world about this question, and we don't really have a precise answer, in fact, but we're just so much further ahead than we were 10, 15, 20 years ago. So I should say that the regeneration of the optic nerve by manipulating the biology is one approach, but there are other approaches. So Dr. Sahel, our department chairman, is the world leader in restoring vision to the blind by another method. So in cases, for example, where photoreceptors, not the cells that we were talking about today, but the first cells that respond to light in the retina, the photoreceptors, they degenerate in a number of ophthalmic conditions, and but that still leaves the retinal ganglion cells in place. And so what Dr. Sahel and his team in Paris and in Basel, Switzerland, had been working on for many, many years is getting the retinal ganglion cells to respond to light themselves. In other words, not wait for the signals to come up through the retina from photoreceptors through the interneurons, but to make the retinal ganglion cells themselves light sensitive. And that team finally succeeded in getting that to work with a kind of a modicum of vision, low resolution, but it's a start. In the case of retinal ganglion cell damage, there are ideas about computer-assisted devices that take in information about the outside world, possibly process that information through artificial intelligence to interpret what those images are and then feed information directly back to the brain, bypassing the visual system entirely. So there are several approaches, and the tech that you heard about today is working with the cells that are there, and but of course after the optic nerve has been damaged, or in the case of glaucoma, if enough time has gone by, those cells are no longer viable. So there's really not much that we can do. But in cases of traumatic injury, I think we have a better chance of still working with the retinal ganglion cells while they remain viable to stimulate them to regenerate axons. And that's what you heard about in these last two talks. So anyway, I'm dodging the question.
Well, no, and I think it's just what it's very hard to put a timetable, of course,
Yeah.
on research, but you, as you said, there are other breakthroughs that are taking place and other research is taking place all the time. As you mentioned, Dr. Sal's working on things to stimulate the nerves or other areas in other ways. Also directly to the brain, we're kind of answering a few of the questions here. Yes, we're working with the Neuralink people and others and how to provide information directly to the brain. So we are really working on everything here, and truly are, from the very front of the eye to the very back of the eye, all the way to the brain. But this area, this optic nerve regeneration, between that, back of the eye all the way to the brain, we've been putting a lot of attention to focus to, and that's what you got the update on today. There are so many questions, which I certainly would have expected. Many of them are very related to the individuals, which we promised to answer those who put them in here. And then any other personal questions that someone asks about the email, it's Mr. Craig Smith. He's he's always assigned to the webinars. And the questions is Craig at eye-and-ear, spelled out EYEANDEAR.org. And then I see that, this one last question I'll kind of let Larry and maybe Taka answer, just in a sense, because you heard about the statins and the research that's going on with statins to regenerate the optic nerve. And I think many people, every time they hear that, it's like, wait a minute, should I start taking my statins, that my doctor wants me to take for my cholesterol to do this? And the answer is certainly at this point we don't know. Am I right in saying that? Is there any follow up from Dr. Mortensen or Taka or others just to kind of summarize that question, because I know that gets exciting. It is an FDA-approved drug. That's why Dr. Kuwajima is interested in studying it, because it is FDA approved, so that means that it could be used. But we're still talking about, again, models that are done in animals. Any comment, Dr. Mortensen?
So for statins, in terms of regeneration, unclear benefit currently, but in terms of patients who have NAION in particular, or non-arteritic interischemic optic neuropathy, the risk factors are basically hypertension, hyperlipidemia. And so if it does happen where someone has NAION in one eye, often I would recommend they follow up with their PCP, particularly for optimization of the risk factors, including taking statins if they do have high cholesterol. But once again, this is more prevention of further vision loss, and rather than trying to bring back vision that has already been lost.
Right. And more than likely, when if these are to ever be used for optic nerve regeneration, it'd be more from an injection directly into that spot. So it's not something that taking your statins is going to affect. But it is exciting, again, and the reason it's exciting is because it is an FDA-approved drug that means that hopefully the translation to be able to go into a clinic is always accelerated when that's the path. I think that's probably as much as we can throw at you in 1 hour, and that's a lot. And everybody, thank you, all of the speakers, all of the panelists, all of the audience. There's a lot of questions. We will get back to you. Please continue to ask. I appreciate Dr. Mortensen's arrival too, because again, having a clinician as part of the team is neuro-ophthalmologists are in very high demand. And so to find someone who has the time and wants to spend time with the research teams, we're always so appreciative. So thank you again. That wraps us up. We will be back as always in 2 weeks. You'll get an email about the next program, which will be an otolaryngology based program, and then we'll be back again in a month with another ophthalmology based program. Thank you, and have a wonderful Friday afternoon.